Next speaker is a close friend of mine, Mike Conti, and he's from the Northeast originally, trained initially in New York, and he was a John Homans Fellow at the Brigham. And in 2008, like all the great pioneers in our ancestry of our country, moved west where there's more opportunities. And he's now chief at UCSF, which has a proud tradition starting back with Dr. Wiley. And Mike's the chair of the Global Guidelines Committee. We're working on a concept with multiple other vascular societies throughout the world to try to rethink how we analyze outcomes and classifications. And Mike's going to talk to us today. Mike, it's an honor to have you here.
Thanks so much, Joe. It's again a real pleasure to be here. Congratulations to you and Dr. Andros and Dr. Armstrong for putting together such a great meeting and bringing together so many people from diverse areas who are interested in this problem. And what I'm going to do is pick up actually on a few of the themes that have already been touched on earlier. But I was asked to focus on this question about treatment failure or re-narrowing, restenosis. And George likes to give me these provocative questions. Will vascular surgeons be left swabbing the deck? These are my disclosures for this talk. You've already heard a lot about this from Dr. Schneider and others about all the options we currently have for bypass surgery. There's a dorsalis pedis bypass. You just heard the expert of all dorsalis pedis bypassers share with you how effective that can be. And we now have all these tools from an endovascular perspective that have really opened up the opportunity to think about different ways to increase blood flow in the leg and have really challenged us to try to figure out every day and every week what to do in which patient when to make the most effective approach and also limit their morbidity. So this is an ongoing question for us week in and week out. In my group every Tuesday morning at 7 o'clock we're looking at angiograms and talking about this and trying to come to consensus. And it is not straightforward. Now when George mentioned swabbing the deck, I have this picture of the lowly seaman who has to come up at the end of the day after, the air fly boys have been up there and the admirals and so forth and clean up somebody else's mess. But the reality is it's really not quite that simple because actually we're all doing these procedures and we're all trying to figure out how to deal with treatment failure from whatever we do. And in fact, the latest data, this is a paper published just a few weeks ago in the Journal of the American College of Cardiology, which raises some very interesting questions about the changing locations and types of interventions that are being done, including the move to the outpatient angio suite and the large numbers of atherectomies that are being performed with fairly limited data. But what you can see here, and I just pulled one slide out of there, is that multiple specialists participate in the revascularization of the lower extremity. Vascular surgeons now perform the most endovascular interventions. The curves with cardiology crossed a couple of years ago, and they continue to increase. So this is not about a specialty that's swabbing the deck for somebody else. It's about all of us trying to figure out how to avoid making a mess and get the best thing done first. Now, the reason that we're talking about this is because, unfortunately, although we have a lot of treatment options, we see that they fail on a regular basis. Restenosis or re-narrowing of arteries occurs commonly. It occurs because every time we treat a blood vessel, we injure it. And every time we injure it, we start a thromboinflammatory response. That's a wound healing response. It's as fundamental as wound healing. We were not designed to react to cardiologists or vascular surgeons. We were designed to survive saber-toothed tigers, and we have a very aggressive wound healing response, and it happens in our blood vessels. Now, we're getting better at this with all sorts of new techniques, and you heard a little bit about drug elution, which may work in the larger arteries, and right now the data suggests it might work in the superficial femoral artery, at least for limited lesions, but it doesn't seem to be working yet in the areas where we really need it the most. So the patients that need it the most are still failing all the time. And unfortunately, once you put a stent in, for example, we have limited ways to really effectively treat that in-stent restenosis. Open bypass often ends up being needed. The question is it a disadvantage to do that bypass after some of these things have already been done, which Dr. Schneider alluded to. Now, how frequent is treatment failure? Frighteningly frequent in current vascular surgery practice. Part of this is because our patients are living longer. We've done a great job with preventing cardiovascular death. Fatal MI and fatal stroke have dropped tremendously. patients are taking statins, they outlive their reconstructions all the time. If you look just for 2 years on the estimated patency of a femoral popliteal revascularization for what I would consider significant disease, the 2-year outcomes you can see range here from 20 to 30% for an angioplasty up to about 75% for a vein bypass graft. So in the middle there's a range of 1 out of every 2 to 1 out of every 3 patients that is coming back needing something else. It's even worse for endovascular intervention if, as Dr. Schneider mentioned, if you look at the below-the-knee vessels, where plain old balloon angioplasty is still our workhorse treatment, and it can work at times. But if you really look carefully as time goes on, and many of these patients need several months to heal and are at risk for recurrence, the primary patency for tibial interventions is not very good. It's about 30 to 40% at 1 year. So treatment failure is common. So why is it a big deal? Maybe it's not a big deal. Maybe people should get endo first all the time. Maybe we should only do a bypass where endo fails. Well, I know that's not correct because I have a practice. And anybody who has a practice in this field knows that that actually is not true, unless you got blinders on. This is a patient who started out getting an intervention for claudication. So they got a long SFA stent there you can see coming all the way down to their knee joint. And then you can see they got a bypass to the tibio-peroneal trunk. Now, by whose definition is this success? So, they had a femtib for limb salvage after a failed treatment for claudication. Fortunately, in this case, the patient did okay. I wish I could tell you this is rare. It's not. It's not rare. The question is, whose definition was a bridge burned? If I did 100 of these operations, would they do as well as 100 straightforward fempops? I don't really think so for most of these patients. They can do pretty well, but I think probably this patient would have been best served by something else. The point is not to analyze in retrospect, but to recognize that everything we do has the potential for unintended negative consequences, whether it's percutaneous or not. And the problem is that those who don't ever get faced with managing these consequences, which are many interventionalists, lack full perspective on this issue. So it's out of their lab, it's out of their hands. They don't see it, they don't know it, and they actually don't recognize it adequately, in my opinion. Here's more examples of doing a bypass after failed stenting. I have many slides like this, the ends of nitinol stents all the way down to the knee joint. Yes, you can usually find a way to do these operations. I don't have slides showing some of the more impressive ones where we've had to do bypasses down to the lower calf and foot in patients who've had previous, for example, atherectomy when they initially only had popliteal disease. Yes, we were able to do the bypass. I don't know that it's actually the same as if we had gotten to it first. Dr. Mills was one of the first to start looking at this. It's always hard to figure this out in retrospect, but some of the questions are, do you really make the operation harder? Do you make it worse? Do the patients not do as well? And he found when he was looking at the results of patients who had undergone SFA stenting for extensive disease that a number of these had significant worsening of their runoff score when they failed. And you would imagine that if you worsen the runoff score, you're going to put that patient at hazard of not getting the same outcome of any revascularization. But we now have a lot better data, and it's all sort of adding up, except for the one paper that Dr. Schneider mentioned. There are several papers that now show that patients who get their bypass after a failed angioplasty don't seem to do as well. Now, here's the basal data that Darren already mentioned, showing the post hoc analysis of the treatment received on amputation-free survival. And you can see patients were not randomized this way, so you have to be careful about this comparison. But the patients who had an initial bypass certainly had a better outcome from their bypass surgery than those who had a bypass after failed angioplasty. Now, this is an association. It doesn't necessarily mean it was causation. But this observation is consistent, and I think you have to believe it's real. Here again is the other paper that was mentioned from Brian Nolan and the group at Dartmouth, looking at the vascular surgery group of New England at almost 2,000 lower extremity bypasses. We already know that if you do a bypass after a failed bypass, that's not as good. What they showed is that doing it after a failed angioplasty was just as bad as having to do a redo bypass all over again, regardless of whether it was failed endovascular intervention or failed bypass. They had similar effects on amputation, graft failure, and major limb events over time. And here's from our colleagues in Italy in 2011, Dr. Spinelli, who looked very carefully at a large group of patients he'd been treating at his center over 4 years. In this group of 460 patients, 273 had had endovascular intervention, and there were 307 open bypasses. He split these out into those that had a primary bypass and those that had a bypass after failed endo. First, you can see that the frequency of pedal targets had gone up increasingly in group 2, but this is perhaps the most striking data. In the group that had had a bypass after failed angioplasty, they had a 24% 30-day failure rate. You should expect for CLI in bypass surgery about a 5 to 8% early graft failure rate at the most. The 1-year patency and amputation-free survival was also significantly better in the bypass patients first. So there does appear to be a real pattern here. And then we, together with the group at Dartmouth, looked again at this New England database with a much larger cohort, and we looked at the changes in vascular surgery practice across New England. So here's a slide that just shows you of all the lower extremity bypasses done in New England over those years at those hospitals in the VSG&E, what percent was not the first procedure in that leg? What percent was a secondary operation? And you can see in the last decade that has doubled to the point where pretty close now to half the time we're doing an operation, it's because something else has failed. So I would say to you that this is actually the new vascular epidemic. We are treating previous treatment failure about as often as we're treating atherosclerosis, and it doesn't seem to work as well. So I think that we have a real thing that we have to consider has become a phenomenon. And if we looked, here is the most detailed look at this that we could try to do in a retrospective fashion. In this group of patients, we looked across 20 different variables that included comorbidities, anatomy, and surgical variables. And after we controlled for all of them, the patients who had a first-time bypass versus the patients who had a previous failure, you can see on these slides for either reintervention or amputation on the left or major adverse limb event on the right, those patients getting the secondary reconstruction simply don't do as well. And one of the most important things on this slide, because the data is front-loaded, you can see that the curve is only 1 year, is that these curves are getting farther apart as time goes on. This problem is getting bigger as time goes on. They just don't last as well. And for most of our patients with diabetes and foot ulcers, they are going to get another ulcer somewhere within the first couple of years. Do you really want to be wondering about your revascularization when that happens? This is something we're thinking about all the time. So, what are the potential explanations for this, for why a bypass might not work as well after you've tried endo? And it's not always going to be the case, and I don't have the answers, but here's some of the possible explanations. One is that this is just a bad patient. Certainly that's possibly true. Some patients may not do well with anything. They may have thrombophilias. They may have terrible conduit or no targets, and they just may have bad biology. As Dr. Legurfo pointed out, sometimes that biology can be overwhelmingly bad and not correctable. So some of that is possible. It may also be true that patients who are bad surgical candidates to begin with are the ones that we're pushing the envelope on in endo, so that when they do fail and we try to do a bypass on them, we've already self-selected the patients who aren't going to be good bypass patients. And I think that's true as well. But I also know for sure that what other things that can happen include changing the distal anastomosis from where it could have been to a more distal target. Embolization of runoff vessels in the calf and foot. I've seen this multiple times. And another thing that I have seen pretty frequently when I go to expose these target arteries that have had multiple catheters run down the tibial vessels, there's inflammation and injury that you can see in those vessels. There was no surgical incision there, and the artery is scarred. It's stuck to the vein, it's scarred up, and it's inflamed. This is because of previous endovascular interventions, and this, I think, also has an impact. And then finally, here's the other thing, and this was really mentioned by Dr. Legurfo. It's really the issue of just delaying effective revascularization. So you have delay in everything, further tissue loss, recurrent infection, and basically the limb stage gets worse. And we already know that if the limb stage gets worse, the outcome of the next intervention is not going to be as good. I think all these things actually occur in real-life practice, And they're not very well thought about in certain venues. And finally, I just want to clarify the point that although we try to do the least invasive thing that we can do for the patient to answer the problem all throughout surgery, we always have to try to think about how that's going to have an impact if it doesn't work. And treatment failure, regardless of what we do, in critical limb ischemia has negative consequences. So, as Frank pointed out, delayed healing, recurrent wounds, increased tissue loss, infection, these are things that patients are dealing with when they don't have adequate perfusion or when it's bouncing back and forth because the treatment fails. And what else do they have? They're immobilized. They can't start walking. They have poor nutrition. The word inanition means basically lack of food and water. They basically lose energy. They have recurrent pain. So all this is going on. They have additional hospitalizations, more procedures, and more cost. And it does, as we mentioned, potentially alter their subsequent treatment options. And it's a psychosocial stress. It really is for the patient and the family to be fighting with this as time goes on. So ultimately what we really believe is that you really want to pick the right procedure first. I sort of call this the plan idea, which is, as already been summarized by Joe and others, patient risk, the limb stage, and the vascular anatomy, you have to take that all together and really be flexible and have all of the options available. We do have 2 trials that are now underway, hopefully going to shed a lot more information than we've had to date. This is the BEST CLI trial, which is a large randomized trial comparing endovascular versus surgical intervention. It started enrollment last year. It's funded by the NIH, and it's a multidisciplinary study. And in the UK, we now have BASIL 2, led by Dr. Bradbury again, which is looking at below-the-knee disease. And both of these trials are active and ongoing, and they're probably going to hopefully finish up around the same time. It's going to take us 4 or 5 years to get the data, but at least we have the promise of more evidence in the future. Until then, this is my algorithm. It doesn't look too different from some of what you've heard today. These are the factors that I look at. Most of them are readily available by clinical exam, by using some risk calculation, and by angiography and ultrasound. I want to know about the surgical risk, the life expectancy, how ischemic is the foot, the limb stage, the anatomy, and whether or not the patient has a conduit. When I see an average risk patient who's likely to live more than 2 years, has major tissue loss, and relatively unfavorable endoanatomy, if they have a vein, they're going to get a bypass. There are quite a few patients that don't fit all that, and we're still trying to figure out what's best for them. In those cases, when they are high risk or have minor tissue loss and endo-friendly anatomy, we will tend to favor endo first as an initial approach, but we're still figuring this out, and we go back and forth quite a lot. Some patients probably should be palliated. Not everybody is a candidate for revascularization. And that's my last slide, just to highlight that hopefully sometime in 2016, this year we're going to be starting this Global Vascular Guidelines project with the goal of getting something out by 2016. We won't be informed by the evidence of those 2 randomized trials, but we will try to bring together some of the best experts for consensus to try to provide a framework for the global problem of advanced limb ischemia. Thank you for your time.
That's perfect. If all the speakers could come up, we have a discussion panel now before the Granita break, and we have plenty of time to do that. Anybody from the audience have some questions? Dr. Taylor.
Yeah, this is Spence Taylor from Greenville, South Carolina. Enjoyed all the talks, and you always love a session that sort of exposes your biases. So thanks for enlightening me. So let me paint a scenario that's happening in Greenville, South Carolina, and it's a story I've created about how things are being handled more and more. And I'd love to hear what you guys, if this is a familiar sounding story, and what are you guys doing about it. So the patient comes in, has critical limb ischemia, has an ulceration. They get an arteriogram, and the oculostenotic reflex takes over. They get an endovascular procedure. The ankle brachial index goes from 0.3 to 0.7. It's an outpatient procedure, right? They go home. They don't get seen for a couple of weeks. The foot sore doesn't really get taken care of, maybe like it should have. Started a wound care clinic. They're coming to the wound care clinic, but it gets delayed. Next thing you know, it's 3 weeks in. Ankle brachial index is 0.6 or so, and the foot's not nearly what it should be. And next thing you know, you got Dr. Conti's situation where you're operating on something that failed, and we're guilty. We're completely culpable because we were there at the beginning. So is this a familiar setting in your practice, number one? And number two, what are you guys doing about it? Thank you.
Well, before you go away, Spence, I have a question. Were you talking about Greenville, South Carolina, or Los Angeles?
Greenville, South Carolina,
okay,
I'm afraid.
okay.
Right.
Thank you. That's all I'm wondering.
Let's start at the end. We'll work our way down.
Frank, do those people need a first-class ticket to Boston?
Okay, I'll jump in. Yeah, sadly, that's common. And I think that the number one problem and the number one thing that we in this room have been, I think, trying to do for a while is to try to fix this fragmentation of care that occurs with these patients who are so vulnerable, and they bounce from one place to another and are failing in between, and they don't get effective care. That's what amputation prevention teams and multidisciplinary units are about, is not to have that happen. The other thing that you mentioned was the outpatient angio environment, the in and out treatment, the lack of follow-up, and actually the lack of effective treatment. And that is a huge problem that I think actually is increasing. It depends on where you are. It's highly regional. The expert is about to talk about it, I think, maybe. But it's not unique to Greenville, South Carolina.
Darren?
Yeah,
you can rant if you want to.
What's that?
You can rant if you want to.
Yeah, I was having flashbacks when you were telling us about that scenario. We have exactly the same issue, and I think that this really has to be addressed at a higher level. I mean, the
Celestial, you mean?
Maybe. The incentives for doing these interventions are really perverse. They're all financially motivated, and really, I mean, I've been called, and we had to deal with a little situation where certain providers, I won't say what specialty they were doing interventions, and we were getting called for wound consults only, and it was really not part of a comprehensive multidisciplinary treatment team. And that's really what's needed. These patients are complex. You shouldn't undertake these interventions unless you have the mechanism to care for the patient as a whole and the wound, and it should be incentivized to set up treatment that way as opposed to incentivizing these outpatient endovascular centers.
Yeah, well, vascular surgeons are guilty of this too. It's not just other specialists, but unfortunately what gets reimbursed is procedures. And a patient doesn't come to you for a procedure, they come to you for care. So what you need to try to do is set up, when we evaluate a patient, somebody gave an outline earlier, but we do a complete physical exam history, try to get their functional status. We duplex them if they have arterial disease. We try to identify arterial disease.
Wait a second, the physical exam, that's where you touch the patient?
Right.
Okay.
But then you put all those things together and try to figure out, for this patient with this wound, with this quality of life, what do we have to offer, and how do we get that foot to heal? And I was just thinking with Dr. Legirfo's definition, when in his era, these were no-option patients. These patients were all getting their legs cut off, and there was no treatment option, and they came up with a treatment option that saved a lot of legs. Now we're kind of in the opposite situation where we have tons of treatment options and multiple providers that can provide some of the treatment. And what we really need to do is create a system where this doesn't happen. So but that happens in our system too, even though we try to avoid it. But the key to these patients is close follow-up, because no matter what you do to them, some of your procedures fail. And sometimes what often drives the scenario you described is an infection that developed and they come in late. We've seen that. Even after a successful endo, you kind of relax because the angiogram looks great, the blood flows better, patient misses an appointment, then they come to the ED with a bad infection. And that infection drives their Wi-Fi stage way up.
Yeah, it's kind of interesting if you think about that one slide that we saw where 17% of legs were removed with a patent graft. And we've all seen that over the years, limb salvage exceeds graft patency. That turns it on its head. Graft patency exceeds limb salvage. I mean, it's crazy. I wanted to say one thing, since I see another fellow with thinning gray hair over on the far end there. In the 80s, there were a whole bunch of papers that came out, and we had a paper that came out in 1982, a long time ago. And it was the same time that the Brigham group talked about secondary revascularization, that paper of Tony Whittemore, Andy Whittemore's, and we had a paper on arm veins that year. And what we found was that if you do an arm vein after a failed bypass graft, which almost all of ours were, I hate to say they were our own failed bypass grafts, by the way, and we stratified the patients. Did you get an early occlusion of your bypass graft, usually from fibromuscular disease, or did you get a late occlusion of your bypass graft, and then you got a secondary graft? So the ones that happened within the first year versus those that happened after 2 years, we found that secondary bypass grafts, secondary interventions did worse. And it didn't make any difference if it was in the first year or the 5th year. So they just do worse. And that's how we all talked about, John Manick and John Porter and myself, we all talked about do the best procedure first. And it's come home to roost. Frank.
I'll just pick up on the problem of ineffective therapy, because it's very easy to get into that here, and it's important that we be very careful to document the effectiveness of anything we do, because otherwise we're hurting patients. And remember, there's one medical pie of money, and when you champion procedures, devices, drugs, whatever, technology that's ineffective, you're paying for it.
Yeah, isn't this the week they wanted to repeal SGR? Philip.
Yeah. Hi, that was a wonderful panel. I wanted to just pose a question. Dr. Conte, you showed that whether we like it or not, 50% of vascular procedures are performed by people other than vascular surgeons, and you've had some great, implementation of new guidelines and new, criteria to measure wounds and effectiveness. How are we going to make sure that people outside of vascular surgery hear about and adopt these global guidelines and Wi-Fi and things of that sort? Thank you.
Well, I'd say for starters, we need to get our own house in order first. So that is an issue, and it's an issue with guidelines in general. I mean, we have a lot of guidelines, and then we have a lot of practice that's, I would say, outside of the pale of the guidelines. The one thing about vascular surgeons clearly now have all the tools to treat the patients, and really from that standpoint shouldn't have a conflict. They're trying to find it's not straightforward what the right thing is to do, but I think that we should first get our own house in order, to be honest, and come to consensus within our specialty. That will help. It may then go from there.
Microphone 2.
Hi, it's Perry Meyer from Hamilton, Ontario. I heard a lot about the timeliness of intervention, and where I'm from, my problem is that getting to imaging is a time-consuming process. So I had heard a few years ago Dr. Gibbons saying that he used duplex Doppler prior to operation, and that was sufficient for the majority of the operations that he underwent. And I just wanted to comment from the panel about why or when is it necessary to go to angiography per se, or even CT angio, etc., over duplex Doppler.
Duplex imaging versus intraarterial contrast or CTA or something. Everybody jump in. That's a good question.
We start with a physical exam right in clinic, and then we do simple tests of perfusion. So the first question is there enough perfusion to heal? So if you have a palpable pulse and normal blood flow test, then you treat the wound. If it's infected, you drain it promptly. If you have abnormal physical exam and abnormal perfusion, we get a duplex immediately in clinic when the patient's first seen to try to see what lesions account for their diminished perfusion. And then we try to figure out, based on those lesions, is it something we're likely to fix endo, open, or which, or both options. And then if we go directly to angio, we already have a plan. This patient has a poor conduit. They are high risk. The lesions look endo amenable. We're going to treat that patient endo. Or they're a better risk patient. We've mapped their vein. It's a great vein. They have long segment disease. we're going to get a really high-quality angio and pick out a target and do that. So, but we get people, if you can't get people revascularized quickly in your system, you need someone to help you with that. Because if your vascular surgeons are committed, they can get the patient revascularized quickly.
And by the way, Darren, before you go next, I just want to know that I doubt that Gary Gibbons reaches his decisions primarily using duplex. Anybody who doubts that, Gary's sitting right there and you could talk to him. Darren?
I would agree with everything Joe said. I mean, I think we use ultrasound and non-invasive testing primarily to screen patients who we suspect have arterial occlusive disease, and somewhat to stage and get an idea if it's multi-level or not. As a sole modality to plan a bypass or an intervention on, that's not the case. And we would use CTA or MRA or formal angiography, and probably in the diabetic foot and the tibial pedal occlusive disease, it's still conventional angiography that's going to be the gold standard because of calcification and other issues which affect some of the other imaging modalities. But duplex is really, screening and for staging and starting to plan, but not the final planning imaging modality.
Mike?
Yeah, I would agree. I mean, anybody with tissue loss, advanced limb ischemia, in my practice that we're thinking of revascularizing needs an angiogram. There just simply isn't a tool yet that gives you that kind of the anatomy you need to plan the revascularization down to the lower leg and foot. Occasionally, for patients with claudication, a duplex and or axial imaging may be reasonable to plan an above knee or fem pop, but anything that's below the knee disease or with advanced limb ischemia, I think still needs an angiogram.
Frank?
Yeah, I think there are situations where you can probably do it, but certainly not in all situations in terms of imaging. But one thing about angiography when you're working below the knee, because you want to go in there with plan A, plan B, and maybe even plan C in mind. And so you don't want to just know if there's a DP. You want to know if that it doesn't look good when you get there, or the vein isn't long enough. You have a perineal to go to, and you know where to pick it up, and so forth. So I think if you really want to do good distal bypass work, you need a good angiogram.
Question?
Hi. I'm Tarek Rashid. I'm a vascular surgeon, so you understand I work in Andrew Bolton's clinic, and I kind of do what he tells me to do. My dilemma is that because I work in his clinic, we get the patients that either nobody else wants to do or people that nobody else thinks can be done. So my question is really on sort of the limits of, it sort of addresses one, the angiosome issue, and secondly, when should we or maybe shouldn't we attempt revascularization, i.e. is it actually worth it? So I'll give you a scenario which maybe you can hang your question onto. So you've got a patient with an incomplete foot arch, a large heel ulcer, probably best off having a bypass. Has a dorsiflex pedis, but it's not going to run right the way around. We've tried an angioplasty to do the plantar pedal loop, hasn't worked. It's calcified, it's not going to do. For this patient, is a pedal bypass going to be worthwhile, given there is an incomplete loop? And the other sort of secondary question, some people have experimented with bypasses deliberately onto the vein, so say posterior tibial vein. Have any of you got any experience of this? Welcome your thoughts.
So, do you want yes or no, or do you want a discussion? Okay. Let's start at the other end, because the definitive paper on the subject came from the deaconess. Frank?
Yeah, well, I think I just showed a slide, Scott Perselli's work, showing that a DP bypass heals up heel ulcers just as well as it heals up forefoot ulcers.
Just takes longer.
It takes longer. It may take 6 months for a heel ulcer to heal, but they will heal, and you certainly should not rule it out just because the ulcer's on the heel.
By the way, since we're on the subject since I brought it up intentionally, say a word or two as we come back this way to answer that question some more, because that's a constant question I get asked. I got a heel ulcer, I got a DP artery, is it going to heal? And the answer is yes. I'd like to hear some other opinions. And also comment on when I speak to patients, I tell them, look, you've been 4 months since you had the ulcer, you've been late getting here. Time to healing is important. So I'd like a comment or two on that, since you also talked about that, Mike.
First, I want to apologize for the working conditions that you must have there. It must be a tough place. My condolences indeed, but congratulations on that. Not all heel ulcers are the same, of course. So, we and others have found, of course, that the large heel ulcers that are deep and involve the calcaneus and are more than 5 centimeters or 6 centimeters in size, particularly if they're in patients with renal disease, those are really, really difficult to recover. And even with effective revascularization, the length of time for offloading is severe, and the options for tissue coverage are really limited. So I think it depends on the size of the defect, the depth of the defect, i.e. the Wi-Fi part of it, and also depends on the patient's overall status. So I think renal failure with a heel ulcer is a particularly bad combination. I have been frustrated with that. I don't say I wouldn't do it, but I think I have a much different conversation with the patient. It can work, but I'm reluctant in that subgroup.
Yeah, we all have those nightmare patients with renal failure and major tissue loss involving the heel, and I agree. I think that probably less than half of those patients we end up saving if it's really advanced, but we still try a lot of them, and I think it has to be based on the individual patient. I think your question about angiosomes and the importance of angiosome-guided or directed therapy is important, because there's been a lot of written on that and spoken about that, especially of late. And I think it's really primarily of academic interest, and maybe it may somewhat be prognostic, but I don't think it stops us from revascularizing people. So yes, of course, if we can revascularize and have a beautiful target in the angiosome affected by the tissue loss, by all means, that's the one we're going after, whether it's with a bypass or endo. But if we don't have a target in the affected angiosome, but we have another viable indirect target, we're still going to go after that target if we think the patient has a reasonable opportunity for limb salvage.
Yeah, I'm told that somebody's writing this up right now. About a long time ago, we started a series of patients that had both forefoot and hindfoot lesions and had both a DP and a PT, and we just did bifurcated grafts on them. And we felt that also helped to shorten time to healing, which we thought, interestingly enough, once the lesions healed, half of the bypass grafts went down. As soon as the lesions healed, one of the two stayed open. So you've got to be creative in this area. Joe?
Yeah, I think it depends on the disease pattern. So I think we're seeing heel ulcers more commonly. In our experience, they're almost always diabetic and usually renal failure. So if they have mostly tibial disease and a good tibial target, then I think a DP bypass is the way to go. But we submitted a pretty large series of patients to JVS, and in their infinite wisdom, they turned the paper down. But Dr. Montero Baker and I worked on this together. He'll talk about it in the next video session. But we called it orphan heel syndrome. So these patients, in our experience, frequently have a palpable DP pulse. If they still have toes left, they have pulsatile toe waveforms, and they have a big heel ulcer. And when you do an indocyanine and green angiogram on them, they don't have any perfusion to their heel. And when you angio them, they have perineal and posterior tibial occlusive disease. So that subset of patients, if you can't get blood flow to the heel, they won't heal. Now, it turns out it's multifactorial. Even when you get blood flow to the heel, I think because they're immune suppressed from their renal failure and they're usually malnourished, and they also tend to have high hemoglobin A1Cs, you still have trouble healing them. But I think the patients are different. But there's definitely, those patients frequently get missed as ischemia because they have normal toe waveforms and a DP pulse. So everybody says, well, it's not vascular. It is vascular. If you angio those patients, they have heel malperfusion.
I'm going to take the liberty of taking these last three questions because it's going to be a long time before you get a panel as good as this one. Keep it short.
Thank you. My question is about the association between physical activity and success of revascularization. As you know, physical activity can increase blood flow to lower extremity. Now, I wonder that whether you have any recommendation of using some foot and ankle exercise to increase the success of revascularization, and on the same note, whether somebody who doesn't have any mobility, revascularization might be beneficial for that person.
Well, mobility is an important issue, and if we have somebody who's non-ambulatory, who has extensive tissue loss, then we're usually not revascularizing that patient, and that patient may be better served by a primary amputation. That being said, those patients who can still transfer and use their limb to some extent, then there is sometimes utility if you think that can heal. I think the exercise point is valid. It's not really been well studied and practiced that widely. I think one of the issues and something that does need to change is there to be reimbursement and payment for exercise and rehab programs, specifically in vascular patients, which there are not, like for cardiac patients, because I think that would be beneficial.
Darren, how long after the operation, let's say you do a pedal bypass or tibial bypass, how long after the operation do you wait before you ambulate the patient?
We don't wait very long at all. I mean, we have patients out of bed the next day.
Okay, next day walking.
Well, walking, it depends on the patient. I mean, we initiate...
you take them for a drag.
We have our physical therapist seeing the patient the next day. It depends on the individual patient how fast you can actually get that up. We don't do specific periods of bed rest for bypasses because it is important to get patients moving. The downside sometimes is also, limb swelling that you can get, and you don't want to pop your incisions open, so you do have to be a little bit careful with that as well.
Yeah, I thought you were going a different way with that question. So we heard from Nick Schopper this morning that mobility was the biggest determinant for quality of life for these patients with foot ulcers. And I don't know if Spence Taylor is still here, but his work on this has been neglected. So one of the biggest determinants of a patient outcome is their preoperative functional status. So if they have markedly diminished mobility and they're in a nursing home already and they can't do much but transfer or not even do that, no matter what you do to those patients, they don't do very well. So in those patients, you probably shouldn't be really aggressive. But there is a subset of patients that are pre-frail where you'll get them and they've been down for a relatively short time, and the reason they're down is because of their foot wound. If that's been fairly short, I think you can revascularize those people and get them aggressive physical therapy and get them back to their pre-frail status and maybe prevent them from being frail.
Dr. Taylor told us that the best predictor of future walking is past walking.
Philip Coleman, I'm a vascular surgeon from Australia. Firstly, congratulations to the US vascular surgeons for getting the numbers above the other specialties. Once the vascular surgeons own the disease, or at least part of a multidisciplinary faculty, you've got a group that can offer both treatment modalities. The problem with a lot of the earlier studies is we don't know whether the initial intervention by the interventionalist was successful, what the durability was like. The second point is, and it's driven by other specialties and industry, patients think everything can be fixed with a stent. And
I wonder where they got that idea.
Yeah. And I'd just be interested how the panel copes with patients, because I've certainly had them where I've offered them bypass, and I've never seen them again, and I've been quite happy with my offer of bypass. I thought that was the best treatment for them. And then later I see them recurrent standing by other interventionalists. I just wonder how you and your institutions deal with that philosophy, because it's something we have to overcome. Because as we know today, not everything can be fixed with one treatment.
I think we're going to suggest we bring back the guillotine. Let's get some comments.
Yeah, I don't think it's just non-vascular surgeons that make the wrong decision. I think all of us do that. Endovascular therapy is very tempting. It's less invasive. It's less work usually. And it works. I'm not anti-endo. Actually, we do a lot of endo, and for the right patient and the right lesion, it works really well. I think where we still don't have a good endo answer is extensive tissue loss with long segment tibial disease. I still think for most patients that are functional and they have a conduit, those patients do better with bypass. And unfortunately, it's tempting. Well, we'll get the tibial open. Angio looks good, flows better. and then the wound stalls. And all of us, I do that still, even though I shouldn't, even though I think I know better. But that subgroup, I mean, Dr. Schneider just showed us the drug-eluting balloons haven't seemed to pan out for tibials yet. So I think long segment tibial disease, which is pretty common pattern of disease, a pop pedal bypass is still the way to go for a lot of those patients if they have conduit.
Final question.
Since Dr. Jeffro is here, in 1997 at the American Diabetes meeting, there was a discussion on is functional microvascular disease clinically significant. And so I know Joe had the Wi-Fi, and I guess my question is, how do you look at the functional disease? I would say it's non-occlusive microvascular dysfunction. And are you all looking at that in your centers if they fail? And how do you assess it?
Well, Larry, since we happen to have the guy, Kaufman and the Leggero in 1984, and he's only about 20 feet from me, maybe we can get Frank to say something about that.
The microvascular dysfunction in the foot, how do you measure it?
Yeah. So there are many things going on in microcirculation. The AV shunting, thickened capillary basement membrane, possibly ineffective transport between the lumen and the interstitium in the foot. The proteins are glycosylated, and whether glycosylated proteins move across the capillary membrane the same way normal proteins do, but certainly people with diabetes have a capillary leak of albumin. So there's a lot of things going on there. One thing that's not going on is not some mysterious occlusive disease in the microcirculation. Just think about it. If the capillaries are blocked, tissue's dead. That's where all the oxygen comes from. So that was a bad idea that put a lot of people off. There's a big difference between blocked circulation and ineffective circulation. Because if you increase the amount of ineffective circulation, you've done something good. And but your question, can you measure it? As I said in my talk, as far as I know, there's no good way to measure not only this, but the other aspects of the disordered biology in the diabetic foot. So the ulcer tells you what's going on in that patient, in that patient's life. That foot can't keep up with it. They've got an ulcer, and if ischemia is a part of it, you should fix it.
Thank you very much, audience and panel. Please, our thanks to this wonderful panel.